Hmm. Hello guys, I'm clearly audible and visible to you. Let me know in the chat box. I'm waiting for your chat on my other screen. I hope I'm clearly audible and visible to you. Please let me know in the chat box. Yes, I can see your chats. Just let me know in the chat box, guys. Just let me know in the chat box. I'm waiting for your replies in the chat box. Yeah, I'm clearly visible on my other screen. Just let me know. Okay, good. Yes, clear, right? Perfect, perfect. Let's wait for everyone join. All set, all set. Right, good, perfect. Just waiting for everyone. They will join. We'll start the session. All good, all good, all good. Okay, right. Okay, so again, this is the same session as we had the ophthalmology session, right? And now we are doing the ENT session here. All right. So we are going to cover up all the important topics and the basics also. Like as you already know, I love to start with the basics, right? First, हमको basic cover करना है. Then we'll going for the clinical part. So right, it will be giving a good way to study. All right, very good. Okay, waiting for your responses, guys. Let's everyone will going to join. We'll start the session. Let's start the session. Let's start the session. Right. Okay, guys. So the same manner we're going to start. I'm going to show you the MCQ in front of you, and then later part I will going to explain you all the importance of that particular topic, which important MCQ I given to you. All right. Okay. Let's start the session. Let's start the session. Simultaneously, you can share your this link to your fellow and your batchmates and colleagues, right? So they will also join this and they will get the benefits of these sessions, right? In the live manner, please try to share these sessions to your colleagues also and batchmates also, right? Because when they will going to join these sessions in the live manner, it will be helpful for them also, right? It will be very helpful for them also. Very good. Good evening, good evening, good evening, doctors. Good evening. Let's start the session. And the first MCQ in front of you. And what is the first MCQ? Yes, guys. The first MCQ is the first MCQ is the what is the length of EAC? So what is they are asking here, guys? They are asking you about the EAC length and how they are divided into the parts. I hope you know about it. This is a very basic and important question for as per your examination, right? As per your examination, and yes, it is needed. There's a very basic question you have to need about it, because sometimes what we are doing, we are focusing on the more clinical aspects, right? And as suddenly they ask you such kind of the one liners that you are getting confused, right? थोड़ा हिंदी में भी समझा देना सर. श्योरली डॉक्टर विल डू दिस सेशन इन इंग्लिश मैनर. ओके, थोड़ा हिंदी थोड़ा इंग्लिश कंबाइंड में चलेगा, राइट? कॉम्बिनेशन, यस, इंग्लिश वे में वी कैन learn in the English manner. Okay, right. So what will be your answers? I'm waiting for your answers, guys. I'm waiting for your answers. So option is given your option A is the 16 mm, and they are asking you about that. There will be the 1/3 is the cartilaginous and the 2/3 is your bony part. Yes, very good. Option B is here 24 mm, 1/3, which is the 1/3 is the your bony part, and then 2/3 is the your cartilaginous part. Option C is saying 16 mm, equal part for the bony, equal part for the cartilaginous, right? So it means one and a half they are want to say. The next we have the 24 mm, and they mentioned here there is a 1/3 is the cartilaginous and the 2/3 is the bony. Now what is your answer? Now, what is your answer? Many of you are replying the B. Guys, please, just one thing I'm going to clear you. Option A and option C is not the possible. ये तो possible होगा ही नहीं, because 16 mm is the not the length. Okay, 16 mm is the not the length of EAC. What is the length of EAC, guys? Reply me in the chat box. What is the length of EAC, external auditory canal length, in the chat box? Just reply. Just reply in the chat box. What is the length of your external auditory canal? Yes, very good. It is your 24 mm. Yes, so length is your 24 mm. So यहाँ पर तो कोई confusion होगा नहीं. But where we are, guys, are getting confused here, you all are getting confused in the bony and cartilaginous. Yes, you are getting confused in the bony and cartilaginous. Okay, so your answer should be here. Please remember, your answer should be here, not the B. The answer should be here, the D. Yes, guys, please remember this. You get confused little bit, right? You everyone was going good with that, with the everyone answered the B, but you confuse with that. Yes, you confuse with that about the bony and the cartilaginous. Please remember about it, as I'm going to confirm you. Please remember, it is a 24 mm is the total length, and the ear canal, which is the external ear auditory canal, it will be going to started with. It will be going to started with the first of all your cartilaginous part. सबसे पहले यहाँ पर this is our ear, and it will be going to start with the cartilaginous part, and after the cartilaginous part it will be go inner side, and inner side will be going to your two-third is the bony part. So for explaining this, I'm going to explain you a little bit in the depth of this the anatomy of our ear. Yes, so please let's move further, right? So please remember, what should be your answer? Your answer should be the one-third, which will be the cartilaginous, and the two-third, which is the bony, right? So the first cartilaginous, and then it will be go bony part. Let's move forward. So please remember, your answer should be your 24 mm. One-third will be the cartilaginous, and the two-third will be your bony part. Bony part. For understanding this, yes, yes, yes. Nose. I am not asking about the nose ना. Nose 24 mm नहीं है possible ना. ठीक है. So don't confuse with it. Don't confuse with it. And now let's move forward. The question is already mentioned EAC. मैंने already highlight भी किया है doctor. We are talking about the EAC, external auditory canal. Okay. Okay, doctor. Now let's talk about it. Let's talk about it. So what is the importance of this image that is shown to you? That is your action, the total ear. Yes, and out of this ear, please remember this part, which I'm highlighting here. This part is the your cartilaginous part. Yes, and the last next part, which is here. This will be totally, yes, I'm dividing it with the black color. I think it will be clearly seen to you now. Yes, this one will be the your bony part. Yes, this will be your bony part. And yes, it's total. I'm talking about here the total ear, right? I'm not talking about the EAC. अभी हम EAC पे नहीं आए. Just I'm talking about it. And also, this is further divided into the three parts. I'm also dividing those three parts also, like the outer color, which is this one. This is known as your external ear. Yes, this is known as your external ear. And yes, this one, which is in the middle one, right? Which is this the middle one from here, right? This one totally. Just a minute. This one is the totally, which is the orange color one, right? So this one is the total one is the your till here, till the tympanic membrane, till the tympanic membrane. It is your external ear. Now after the external ear, very small part, this black color line which I'm drawing here, guys. This black color line which I'm drawing here, this will be your what? This will be your middle ear. Yes, this will be your middle ear. And the last one, which is the innermost, right? So the last one, which is the innermost part, I hope you can see here, which is in the covered by the bony covering. Yes, and this will be your inner ear. Yes, this will be your inner ear. Is it clearly visible to you, everyone? Right? So this is the your inner ear. Yes, very good. So external ear, which is the big part you can see there. Then just behind the tympanic membrane के पीछे जो part है, that will be your middle ear, and the last one, which is the inner side, which is your bony part. That is your bony part, which is in the covered in the bony part. That is your inner ear. Yes, that is your inner ear. Very good, guys. Very good. Now, where this ear is situated, so write it down with me. Where this ear is situated, write it down. That ear is inside the petrous part, guys. Please mention here very well. This is in the petrous part of what? Of temporal bone. So this, our ear is situated on the temporal, right? On the temporal bone. You know about it, the temporal bone. And this temporal bone is in the which part? Petrous part. Okay. Yes, petrous part of the temporal bone, right? And please remember, this is the hard part of the temporal bone, right? We can say it is the very hardest part or the bony part, which is the hard in the bone, right? The next, if we are moving forward for the next, what is the importance of this? Please remember, if we're talking about it, the auricle, which is your this helix and the auricle, right? So ye wala part, jo auricle wala part hai, this auricle will be going to developed by your elastic cartilage. Okay, so this auricle part will be divided by your, yes, this will be all your elastic cartilage. Okay, elastic cartilage. And please remember, this is made up of elastic cartilage, so that's why this is very elastic. You can see it is a very mobile, right? It is a very mobile, you can see little bit mobile, ऐसे हम mobile कर सकते हैं, move कर सकते हैं. So that's why this is made up of your elastic cartilage. Very good. So this auricle is made up of your elastic cartilage. And if I'm little bit going to talk about the your, it will be talking about the your development of the your pinna also, right? What is the pinna? This is the your pinna, the total pinna, right? So this pinna will be going to develop, from the your first and second brachial arch in the embryology. But here we have to talk about not the embryology, the important question which is asked about the EAC. So let's talk about the important, which is your EAC, external auditory canal. So let's talk about the external auditory canal. So you can see here, it will be going to start it from here, the external auditory canal, and it will be going to end up on the tympanic membrane. So if I'm going to highlight it with the white color pen, so you can see clearly, right? Just a minute. Yeah, I hope is it clearly seen to you. So this part, which I'm highlighting with the white color, right? So this is your what? Yes, this is the your EAC. This is the your external auditory canal. Very good. As we already talked about it, what is the length of it? It is your 24 mm, right? What is the total length of the your EAC? Is the 24 mm. And please remember, this is your first part. Can you see this first part? As we talked about it, it will be your totally cartilaginous part. So you can see this part, which is the your one third part. So your first one third, which is the first one third part, is the cartilaginous of it. And later one part, you can see this one, which is in the inside the temporal bone. You can see this one, which is the two-third part of your EAC, which will be your bony. Yes, this will be can be your bony part. Very good, doctors. Very good. The one third part in the starting, it will be your one third part will be your cartilaginous, and the later two-third part will be your bony part. And what is the important of it? Please remember, it is not the straight, right? You can see here, it is a little bit moved forward, so it is having the S-shaped structure. Yes, it is your S-shaped structure. And with the S-shaped structure, the important thing which you have to remember, I'm making a star mark here and write it down. It is lined by your squamous epithelium. Yes, it is lined by your squamous epithelium. So you can see there will be the your external auditory canal. It is totally lined by the epithelium. And which epithelium is there? Yes, guys, this will be your squamous epithelium. Squamous epithelium. Also, with the squamous epithelium, guys, there is the two important glands are present there, right? In the ESE, there's the important glands. And what are those glands, guys? What are those glands? Please write it down the name with me. The first one, which is your sebaceous gland. Yes, the sebaceous gland. The second one, which is your apocrine gland. Okay, so what will be it will be going to secrete, guys? As you already know, your sebaceous gland will be going to secrete your sebum, and that apocrine gland that will be going to secrete your ceruminum. So this both will be going to make there, and it will be making lining over the your EAC to protect with the bacteria. All right, so as the bacteria will be going to enter inside, this will be going to protect. Guys, please remember, it is not making wax. So what is the wax? Please remember this part. The sebaceous gland, what will be the produced by the sebaceous gland, and what is the produced by your apocrine gland, which is your sebum and ceruminum. These are the fatty, these are the your fat, and this is having the antiseptic property, right? And if with this there is some dead skin or the dust particles which is going inside, if they all are together, will be going to known as the wax, right? So this is not the wax. Just write it down about the wax. If I'm talking about the wax also, just if I'm talking about the wax also, so just write it down what is the wax contains. Please remember, right? So what is the wax, right? Ear wax. If they are asking you ear wax, what is the ear wax, guys? Ear wax is having the sebum, right, which is from your serum, your sebaceous gland. Yes, very good. Then cerumen plus there should be the some dead skin, dead skin particles plus some dust. Yes, some dust particles will be also available there, and this will be known as your earwax. Please remember your sebum and ceruminum. These are your fatty tissues, or you can say the fatty or lipidic. Okay, and of course, it protects from microorganisms. Yes, so this will be going to protect us from the microorganisms. Microorganism. Is it clear to you, everyone? Right? Is it clear to you, everyone, about the wax, earwax? An important part of this. Please remember, related to the EAC, you have to remember the length. You have to remember the first cartilaginous and the second with the bony part, right? So 1/3 which will be the cartilaginous and the 2/3 will be the bony part. And this is our MCQ related to your anatomy, related to your anatomical of your ear. Yes, your anatomy of your ear. Should we move forward? Should we move forward? Just a minute. Let me know in the chat box. Should we move forward? Let me know in the chat box. Right. Very good. Very good. Let's move forward. Let's move forward for the next MCQ. I'm moving forward for the next MCQ, which is in front of your screen. All right. Now, now, which area of brain does the final perception of the audio? So it is talking about the brain areas, all right, which will be doing the final perception, right? The final perception of your audio. And the option is given to you. Option A is your lateral geniculate body. Option B is your broadband area 42. Option C is your medial geniculate body, and option D is the cortex of the brain. All right, so this option is in front of you. I'm waiting for your answers in the chat box, guys. Please try to reply me in the chat box. Please try to reply me in the chat box. I'm waiting for your answers. Guys, I'm waiting for your answers. Lateral geniculate body is of course for the vision. Very good. Very good, doctor. It for the vision. So this should be not possible. Very good. What should be then answers? What should be then answers? All right. It should be the your. What should be the your answers? I want to know about the answers, guys. Very good, guys. You all are replying. Option B is there. Of course, this is the Broadman. Guys, please remember the cortex is the whole. The brain cortex will be there. It's not only the final perception will be done by, and of course the medial geniculate body. It is your in the auditory pathway. It is in your auditory pathway, not in the perception. Okay, ये perception नहीं करता है, that is only carrying the impulses till to the your cortex, yes, to till to the your broadman area, yeah, till to the brain, but it is not doing the perception. Okay, so perception is not done here. So please remember, yes, of course it will be your broadman area. It will be your broadman area 42. Now what is the broadman area 42, guys? As you can see in front of your screens, right, there is a brain function is written here, right? All the brain functions is given to you here in the explanation, and you can see here, yes, very good. E. coli ma is your pathway. Very good, doctor. It is about the pathway, right? We'll talk about it that also, right? We'll talk about the pathway also. Just wait for it. Now, just I'm talking about the importantly. Now I have to talk about that. What is your final your perception, right? Where will be done by the final perception, right? So for this final perception, you can see here. If I'm talking about the sound or the auditory, so this is the your sound and auditory area. And this sound and auditory area, we have the only two areas, Broadman area 22 and the Broadman area 42. Yes, Broadman area 22 and the Broadman area 42. Yes, so this is 22, area number 22 and area number 42 is there. So this is 22. This 22 is the doing the initial process of it. But what is the final perception? Yes, your final perception is done in this area. Your final perception is done in this area. So you have to remember this by the physiological function. Of course, there is some more function like executive function, which is done by the frontal lobe. Some motor functions are there, which is done by the parietal lobe. Of course, we talked about the visual also in the ophthalmology. So you know about it. The visual is done by the your occipital lobe. Yes, so this is the on the your occipital lobe. Just below that we have the memory. Yes, memory and your emotion regulation. These are in front of you, right? There is a on the parietal lobe, it is divided in the somatosensory and the attention also. So these are the area which is divided there, which will be going to help us in the perception and the working of the your brain, right? So please remember, your final perception is done at the Broadman area 42. Broadman area 42, right? For the audio, right? For the audio, right? Audio and the sound, right? The both is there, right? For the auditory and the sound is there, right? Very good, guys. Let's move forward. Before moving forward, just I want to ask you one more question. As I got this thing, we talked about the EAC. There's the external auditory canal, which is you can see this one, right? I want to ask about it, guys. What is this canal is known as? I'm highlighting it with the red color. Can you see here? Can you see here? Can you name me this canal? Just I saw one comment in the chat box. So I want to ask you about what is this canal? Can anyone if you can tell me about this? What is this? What is this? Which is connecting your middle ear. You can see this is the middle area, right? Can anyone if you can reply me in the chat box? What is this? Very good, guys. Very good. It is your eustachian tube, right? This is your what? This is your, yes, this is your eustachian tube. Very good. This station tube, guys, can we talk about this station tube also? Like how much is the length of this station tube? Because as we talked about it here, that your external auditory canal, yes, your external auditory canal is having what is the length and how this is going to divide it. So maybe they can ask you about this your station tube also. Just write it down, one important thing. Yes, very good. ET. Yes, write it down about the ET. What is the ET? Write it down the full form also. Eustachian tube, right? Can anyone of you can tell me what is the total length of Eustachian tube? What is the total length of your station tube, guys? Because it is a similar question, right? Maybe they, as I created the MCQ for their external auditory canal, maybe they can ask you about the same question for the station tube also. Can anyone of you can tell me what is the total length of the your station tube? I'm waiting for your answers. And then tell me how much is the cartilaginous part, how much is the bony part, which is the first, right? Which will be the first will be there, right? Very good, doctors. Very good. You all are studied very well. So write it down. Your total length of station tube is the 36 mm. Write it down. Yes, guys, it is your 36 mm. All right. Now tell me, how much is the bony part and how much is the cartilaginous part? How much is the bony part and how much is the cartilaginous part? Yes, outer is the 12 mm. Of course, it will be going to divide it in the 1/3 and the 2/3. Of course, the same pattern it will be going to divide it, right? Of course, it will be same pattern will be going to divide it as we divide the external auditory canal. But what will be the difference? Now tell me, what is the, how much is the 1/3 is what? 1/3 is what? Yes, of course, this 2/3 is, write it down. आप लोग ये भी लिख सकते हैं inner part. Yes, this 2/3 is inner and this 1/3 is outer. Yes, this 1/3 is outer. Now tell me, which is the bony part and which is the your, which is the bony part and which is the your cartilaginous part? I want to ask you about it, guys. Please try to reply me in the chat box. Please try to reply me in the chat box. Which one is the bony part and which one is the your cartilaginous part? Very good. Very good, guys. Please remember here your 1/3, which is the outer part, it will be here bony. And your 2/3, which is the inner part. Yes, 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 doctor. Your 2/3 part is the your cartilaginous. Yes, cartilage. Okay, I hope you understand this thing. I hope you understand this thing. Just please remember, just I'm comparing with the EAC, right? What we had in the external auditory canal, the total mm is a 24 mm, and the outer 1/3 is the cartilaginous, and inner 2/3 was the bony. So I hope you confused with it, right? As the doctor is written there, sir, we confused with the nose. No, guys, you confused with the station tube. Now you confused with the station tube. Please remember, yes, bony is the outer part. Bony is the outer part, which is the 1/3. Yes, 1/3 is the bony. So now please remember this here. The bony is in the station tube, 1/3 is the bony and 2/3 is the cartilaginous. But if I'm talking about the your, if I'm talking about to your external auditory canal, you can see here 1/3 is the your cartilaginous and the 2/3 is your bony. All right, and please remember about the length. The 24 mm is the EAC and the 36 mm is the your station tube. Is the station tube. Right? So don't confuse within it, right? I hope you confuse with that question. That's why this, as suddenly I saw the comment on the screen, so I thought I have to cover this station tube also. Right? Very good. So please write it down. This about the importance. Now, one more important. We can write it down here. What is the important, guys? Please tell me. Station tube opens where, right? So this station tube opens at where it will be going to open? Can you tell me? Can you tell me where will be going to open? Right? This ET will be going to open. Where will be going to open this station tube? Anyone of you? Very good, guys. Write it down. There is a lateral wall of. There is a lateral wall of nasopharynx. Yes, yes, guys. Tensor will be palatine. There will be the muscle. It's about the muscle, right? Right. I'm asking about here. Yes. Here anatomy and physiology दोनों क्लियर हो रही है. बिल्कुल 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 डॉक्टर, राइट? सो कैन यू सी हियर, Can you see here? This not I'm not talking about the guys about the tensor palate. I'm talking about the location, guys. I'm talking about, I know this is the wall, but where it will be going to open? Yes, it will be open at the lateral wall of nasopharynx, guys. It will be going to open at the lateral wall of nasopharynx. Okay. I hope is it clear to you. So please remember this part. All right. Please remember this part. Just write it down. What is the function of it? Can you tell me what is the function of your eustachian tube? What is the eustachian tube function? Of course, it will be going to manage the pressure. Okay, it's manages the pressure in middle ear. Write it down, in the middle ear. So it is making management in the pressure, like what we have the outside the pressure and what we have in the middle ear pressure. So it will be going to manage, right? It will be going to manages the, yes, it will be going to manage the your pressure of the your middle ear. Yes, of course you can write it down also. It will be going to ventilate the middle ear. Of course it will be going to ventilate the middle ear, and also pressure also. Yes, pressure at the height when we are going into the flight race, right, in the aeroplane, right, there will be also the same. Very good guys, right? So this is the station tube function, right? So I hope you're confused with this. So please remember in this, now I'm giving you one mnemonic, you can remember for it. Just write it down here. Write it down your ET, station tube, and write it down your, yes, write it down your, write it down your EAC, right? And please write it down here, one third and two third. Write it down, and write it down here also, one third and two third. I hope you will be going to remember the length of this, like 24. Write it down here is small 24. Write it down here 36. But main confusion what will be there? So please remember, here will be, this will be your, this will be your, the first in the station tube. If I'm talking about, it will be your B and C, and here it will be your CB, right? So just remember like that. Make a small box will be on the side of your notes. I think it's not clearly visible to you. Just a minute, guys. Just a minute. Sorry for this. Sorry for this. Sorry for this disturbance. I hope now is it clearly seen to you, right? Now is it clearly seen to you? Okay. So can you see here? Can you see here now? That station tube is 36. First, one third, write it down like one third, two third, and in the ESC also write it down one third, two third. So please remember, your one third is the B and C. There will be in the BC is the for the station tube, and the CB is the for the your EAC. So you will be never ever going to forget with this mnemonic. With this mnemonic, is it clear to everyone? Is it clear to everyone? Should we move forward? Very good. Very good. So we talked about this, about the Broadman area 42 also, right? We had talked about this, about the your physiology function of the your brain, physiology function. Now, talking about the next question now, which is in front of you. Reply me, guys. Very good. Reply me in this. The question is asked here that the question is asked here 32-year-old boxer. Clearly they mentioned the boxer, right? With presents with the what? He's come to you with the what? Yes, it comes with the your swollen and painful ear, right? And what is the your diagnosis? The picture is clearly seen to you, guys. The picture is clearly given to you, and the option they are asking you about the perichondritis is there, or their meningitis bullosa hemorrhagica, otitis externa, or the hematoma auris. Guys, what is your answers? Guys, what is your answers? I'm waiting for answers. Many of you are replying the B, right? Guys, why the B? Why the B? Why the B? Anyone of you can tell me why the B? Why you guys are replying B? Please try to think about it. As they clearly mentioned the boxer, and you can see here it is clearly there is a you can see here, maybe there is a due to the trauma. Yes, trauma is surely will be there. Yes, trauma तो वहाँ हुआ ही होगा, as the boxer is there. So of course what will be seen, there will be the maybe the punch, right? Boxer है तो punching तो करेगा ना, right? So maybe there is a punch over the ear. There will be the punch over the ear can be seen there, right? So option which are confusing us here in this condition may, of course it will be not, of course it will be not the or otitis externa. That's I know about it clearly, right? Because otitis externa, it will be not going to swelling up your all the pinna and everything, right? So it should be never ever the otitis externa, and of course it should be not the your Maringitis bullosa hemorrhagica. Now the option which will be going to confuse you, the perichondritis, because the perichondritis is what? Because this is totally made up of your cartilage. Yes or no? Write it down. It is made up of your cartilage or not? Yes. Yes, it is made up of your total cartilaginous part. So it can be your perichondritis also. Yes, it can be your perichondritis also. Now think about it. Think about it. As it is a clearly mentioned, the boxer will be there, and of course, as I can see, as I can see in this image, there is a fully swelling in this area, and the redness will be also seen. Yes, so this is what, yes, this is what, this is the your boxer's ear. It is also known as your boxer's ear. Yes, also it is known as your hematoma auris. It is also known as hematoma auris. And also if you are not, if you are seeing this condition, it is also known as, it is also known as cauliflower ear. Yes, so it can be the hematoma, or it can be your boxer's ear, and it can be your cauliflower. Very good, doctor. It can be your cauliflower ear. Yes, it can be your cauliflower ear. Yes, cauliflower ear. Very good. Let's move forward. Let's move forward. Now, just tell me, what is the treatment of this part? What is the treatment? Very important thing, because what we're going to do in the hematoma condition, what we will going to do in this hematoma conditions, right? Any one of you, for this hematoma condition, what we have to do, right? And also the one important question which they can confuse you, why it's not the perichondritis. Why it cannot be the perichondritis? Because in the perichondritis also, because it's the total perichondrium. Yes, it is the cartilage. The perichondrium is there. If the inflammation of this is also there, maybe there is a totally swelling will be seen. Why it will be not there? Just remember about the perichondritis. Just write it down here. There will be the redness. Yes, redness will be there. Of course, with the redness, there will be what? There will be the fever will be going to see. As the inflammation is there, so of course the fever will be going to seen, pain will be also there. But the important sign which you have to remember in this condition, please remember, in the perichondritis, please remember this part which is known as your lobule. I'm talking about, guys, here about the perichondritis. As the perichondritis, there is a perichondritis. The clearly mentioned that it is the cartilaginous. Can you tell me, is there is a cartilage part in the lobule? Can you tell me in the chat box? क्या यहाँ पर cartilage part है क्या lobule के अंदर? Can you see? Can you touch and feel it? Just feel it the lobule and feel the your helix, right? Which is the auricle, right? Just tell me, is there any cartilage is in the your lobule? Let me know in the chat box. Let me know in the chat box. Yes or no? Of course, no. Right? So in the lobule, write it down. There is a no cartilage. So if there is a perichondritis, will be going to seen. What you will be going to seen? This total part is the seen reddish. Fever will be there. The patient will be giving the history of fever. Of course, the patient will be going to give you the history of fever. pain and the redness in this area. But please remember, this area, the lobule will be totally seen what? Pale. Yes, totally pale, because this will not involve in the pericondylitis. Lobule is not involved in pericondylitis. Yes, as the clearly mentioned, pericondylitis, inflammation of areas. Of course, there will be no. Of course, very good, guys. What will be the treatment? Immediately, we have to do the. Please write it down. Do the immediate what? Aspiration and drainage. I A and D. Yes, aspiration and drainage. Of course, if there is a hematoma, देखो अगर वहां पे bleeding clot बन गया होगा, so aspiration नहीं हो सकता, then incision and drainage can be do. ठीक है, IND can be also do. If there is a fresh, immediately if the fresh hematoma is there, we can do aspirate with the syringes, can be possible, right? But if there is a hematoma is totally there, so we have to do the incision. We have to give the incision. Yes, doctor, right? Aspiration can be done immediately. Yes, so I did written there. Immediate is the aspiration and drainage, and if the later part, we have to do the incision and drainage. Perfect. Very good. Right, so we have to do there. Yes, pressure bandage will be after the after this incision and drainage. We have to do the pressure bandage, so there will be the no bleeding more will be there, right? So pressure bandage will be done later part. Of course pressure bandage will be applied there. All right, is it clear about this topic related to your hematoma auris, right? It is a very important topic. It is a very important topic, right? Very good, very good. Let's move forward. Let's move forward. And the next question is in front of you. Now tell me, what is this procedure? First, tell me, as it is shown in the image clearly, and it's clearly written also, that what is not the complication. Please remember, they are talking about the complication associated with the ear syringing. As you can see, the doctor is doing the ear syringing of this patient. Yes, the doctor is doing the ear syringing of this patient. So they want to ask you, what is the not the complication? So what can be the complication? Can you tell me what can be the complication? Just tell me what not. The answer, if you are giving the answer of this or later, this will be the both will be the same. Right? Just tell me. Just tell me what will be your answer in this part. The option is given. The option A is your tympanic perforation. Option B is the middle ear infection. Option C is the labyrinthine stimulation. And yes, option D is your syncopal attack. Now tell me, guys, what will be the not the complication? Guys, please don't forget in the hurry. You are not seeing this words, which is the not, accept, and kind of the words which is the mentioned by the examiner, right? Which is the mentioned by the examiner. You are not seeing such important. You are not seeing the such important words, right? You are avoiding them, guys. What should be not the associated with the syringing? So the first of all, as we talk about one by one, right? Let's talk about the one by one. What about the option number one? Of course, the option number one, which is the tympanic perforation, can be seen with the syringing if we do the syringing with more pressure. Yes, if you are applying the water, yes, if you are applying the water with the more pressure, right? If you are applying the water with the more pressure, of course, it can be perforate. Yes, it can be perforate the your tympanic membrane, or please remember, as there is a small perforation, maybe there will be on the tympanic membrane, there is a small perforation is available. Is the small perforation, the छोटा सा एक छेद बना हुआ है, right? Perforation start ही हुआ है, and we did the syringing. As I did the syringing, what will be happen? It will be going to pressurize that particular area, and of course there will be the tympanic perforation can be seen. So it will be not a it will be of course a complication of the syringing. So it will be not the answer, right? It will be not the answer. Now let's talk about the option number C. What is the option number C? As you already know, when we are doing what is the labyrinthine stimulation, as we are doing the syringing will be there. So due to the syringing, there will be the labyrinthine stimulation can be seen. So because of that only, to avoid the labyrinthine stimulation, what we have to do, of course, the first thing which we have to do, we have to use body temperature, water. Water, it means your normal saline, guys. Yes, body temperature, water or normal saline, we have to use for syringing. If I'm not using this, if I'm not using it, what will be happen, right? If I'm not using it, what is the approximately, it is your 36.9 degrees Celsius, right? The temperature, what we have to use, the 36.9 degrees, right? So if I'm not using it, what will be happen? What will be happen if I'm not using it? If not, I'm writing here, if not using it. So what will be happen, guys? Please write it down. It will be stimulate the, it will be going to stimulate the lateral semicircular canal. Lateral semicircular canal, right? Right, so what will be happen if there is the temperature is very, yes, high, maybe there is a cold water or maybe there is a warm water is used for the doing the syringing of it, we are not using the body temperature water, it will be what, it will be going to do the stimulation of the lateral semicircular canal. And with this, remember this, if the lateral semicircular canal is stimulated, there will be seen what, there will be the seen the first thing which is your vertigo. Vertigo will be there, and of course vertigo with the nystagmus, guys. Yes, so vertigo and nystagmus will be going to seen, and of course this vertigo and nystagmus is what is known as, it is known as your labyrinthine stimulation. Labyrinthine stimulation, is it clear to you about everyone about the option number C also? Yes, it will be also present. Yes, it can be also present. All right, very good. Now what about the option number D? Of course, it can be also a big complication, right? If there is a nystagmus, and if there is a nystagmus and the your nystagmus and the vertigo will be seen, if it is remain continue, it can cause the your, it can cause, of course, yes, it can cause the your, it can cause your labyrinthine, it can cause your syncopal attack also, so it will be also present. So what is your answer, guys? Your answer is your middle ear infection. Of course, your syringing cannot cause the middle ear infection, guys. It is never ever possible that after the syringing is the done by the syringing, it will be going to complicate you. It will be going to give the complication of the middle ear infection, right? So please remember, whatever the other I already told you, maybe they can ask you about this also. Just write it down about the one important thing for the syringing, for the ear syringing. There is a position for the, we have to do the position of the, yes, we have to do the, yes, the direction is the posterior superior. Very good, doctor, very good. Posteriorly on the superior side we have to do it. Yes, the one important thing which you have to remember, we have to put, yes, we have to put the syringing on the posterior superior. But what about the direction of the, what is the direction of, can you see by the one hand the doctor is pulling the, what we are pulling the pinna, yes, so what is the direction of the pulling this pinna? Please remember, for pulling the pinna I have to give you mnemonic, which is the UBO. Yes, what is the UBO is saying to you? You have to pull the pinna. The first is your upward. You have to pull the pinna on the upward side. After the pulling the upward, you have to pull the pinna backward. And after the pulling the upward, backward, and now pull this your outward. Now what will be happen with this, doing this, as you already know that there is a, Your EAC is like that. Yes, as shaped structure. So as I will do the UBO, I will do the upward, backward and outward. This will be going to become straight. This will be going to become straight, and of course I will be going to put the syringing on the posterior superior side. I will going to do the syringing at the posterior superior side. Is it clear? Yes. Yes, UBO, upward, backward and outward. Please remember this, make a star here. What is this? This is your pinna direction. Yes, the direction of the pinna. We are talking about here in the direction of the pinna. Direction of the pinna. Is it clear? Should we move forward? Should we move forward? Yes. So this will be your middle ear infection will be not caused by this. This will be the not caused by this. Now, and why we are doing the syringing, guys? As you already know, we are doing the syringing for removing the foreign body, for removing the wax and everything, right? For the removing the foreign body and the removing of the wax. Yes, yes, yes. Of course, guys. Okay, very good. Let's move forward. Let's move forward. The next question is in front of your screen. The question is sent to you: a 12-year-old male with the pain. The male is kind of a boy, right? The 12-year-old boy is there, right? So this boy is coming with the pain and bulging drum in the left ear. It means the tympanic membrane, guys. What is the bulging of the drum? What is the drum? This is your tympanic membrane. Yes, the drum is your tympanic membrane. And for Myringotomy, so what is the mean? There is a clearly mentioned, they told you we are doing the Myringotomy. Guys, what is the mean of Myringotomy? We have to put a cut. Yes, we have to put an incision we have to put the incision over the tympanic membrane, and after the putting this incision, there will be all the fluid which is coming out. So this is the case of what? This is the case of serous otitis media, SOM. Is it clear? What will be my diagnosis here? Yes, my diagnosis is said here that, sir, of course, we are putting this on your serous otitis media. There will be the serous otitis media will be going to see. Yes, very good. Now, in this condition, we have to do the syringing. Oh, we have to do the Myringotomy. Yes. So in the Myringotomy, guys, tell me at which location I have to do the Myringotomy, which quadrant. So we have divided our eardrum into the quadrants. Yes, and we are talking about the incision should be given where, right? Yes, of course, this is your serous otitis media. Of course, this is the 12-year-old children. There is a no fever and nothing will be seen. If the fever will be there, we talk about it. There will be some ASOM, right? Acute, right? But there is a no fever. They didn't give any the about the fever. Just the pain is there and the bulging of the eardrum is seen, right? So we can say in this also SOM is also known as, guys, glue ear. Yes, the SOM is also known as, yes, it is also known as the glue ear. Very good, very good. Now tell me, guys, now tell me where should we do the incision? Incision should be your antero-superior quadrant. The incision should be your B option, antero-inferior quadrant, and the option C is your posterior-inferior quadrant, and option D is your posterior-superior quadrant. So just I'm giving you a little bit about the quadrants, information about the quadrants, that this is the my ear, and of course this will be the handle of malice will be going to there, right? And this handle of malice, on the basis of this handle of malice, what I will do, I will make a imaginary line here. Can you see? On the basis of handle of malice, I'm making a imaginary line here. And of course, on the umbo, what is the umbo? And the part of the over handle of malice, I'm drawing one more imaginary line on the basis of the umbo also, right? And by this there I'm getting that my tympanic membrane is divided into the four quadrants. Yes, my tympanic membrane is divided into the four quadrants. What are those four quadrants? Can you see? This is the your anterior superior. As you can see, it is the superior side. Yes, this is the superior side. This is the inferior side, and this is your anterior side, and this is your posterior side. So this is your anterior superiors and yes, handle of malice, right? And this is the posterior superior. This one, this will be your anterior inferior, and this one will be your posterior inferior, right? So this is the four important quadrants which you have to remember, right? Which you have to remember. Now tell me guys, where we have to should to do, where we have to do the Myringotomy. Guys, for the Myringotomy, please remember, I'm writing down here. Please remember, what is this Myringotomy? What is this Myringotomy? We have to make incision. We have to make incision on tympanic membrane. Yes, so as I will cut the tympanic membrane, I will make a cut, small cut on the tympanic membrane. This is known as the Myringotomy. And what will be the use of this cut? Please remember, the whatever the fluid which is accumulated inside the tympanic membrane, which is in the middle ear, this will be going to getting secreted or getting exited from the our external auditory canal, right? For that's why we have to give it. And of course, please remember, it can be given. Yes, it can be given. If they're asking you, ventilation tube will be provided, so we are talking about it. But please remember, in this condition, yes, in this condition, Myringotomy, right, we have to do the opening of the tympanic membrane. We have to done in the antero-inferior quadrant. Yes, of course, the some books are saying that we can do the posterior inferior quadrant also, right? But if I'm talking about in the condition of the SOM, please remember, I'm talking about the here serous otitis media. So in the case of serous otitis media, as the children, there is a 12-year-old male patient will be there. So what I will do, I will be going to put this, I will going to put this cut or the incision at the, yes, I will going to put this into the your antero inferior. Now I can show you this thing, and with this I'm going to show you, yes, I will of course explain you what is a garment. Yes, what is a garment, we'll talk about this garment also. So can you see, in this condition I can divide up this your ear into the four important quadrants, right? Four quadrants I divided it, and this is the your what, yes, this is the your antero-inferior quadrant. And this antero-inferior quadrant, we make a cut there. But what can be happen, guys? Yes, what can be make happen here, guys? Your this cut can be getting repaired. Yes, so tympanic membrane can be repaired there. So we put there a tube. Yes, which is also known as, yes, which also known as ventilating tube. Yes, it can be also known as the ventilating tube, and the also it is known as garment. Yes, yes, doctor. Yes. G for glue ear, G for garment. Yes, exactly. This is also the mnemonic, guys. Very good mnemonic, right? So this is your garment insertion, right? Garment. This is your garment. So what is this garment? Yes, this is a very small particle of a plastic, right? We are putting there, and yes, after the putting it, after 6 months, we have to remove it. Yes, we have to remove it also, right? So we have to remove this garment also in the later part. So we given the cut, which is your Myringotomy, and after the Myringotomy, we put it this ventilated tube, which is known as your, we're putting the ventilation tube or garment insertion, right? Garment insertion, right? So is it clear to you about everyone? Is it clear to you? Is it clear to you about the where we're going to put the Myringotomy incision? Yes. Please remember, it will be your antero-inferior, in the antero-inferior quadrant. Very good. Very good, guys. Let's move forward. Now, the next is in front of you. The next question is in front of you, that is asking you about it. A male patient is with hearing loss. Guys, the clearly mentioned, the highlight, please, first of all, as you are seeing the question, just highlight the keywords. Maybe this is related to some with the male, so I highlighted the male, and then hearing loss, and the patient is having the sensation of a fullness in the both ears. The patient is having the both side fullness of the ear. Yes, the patient is feeling like there is a fully ear is filled with the sub fluid, or maybe it is a fully filled with the anything else, right? So you have to remember. So this is want to ask you, like, which type of tympanogram, guys? What is a tympanogram? This is the type of investigation where we are talking about the movability, how much your tympanic membrane is movable, right? So we are talking about the how much is your tympanic membrane is movable. This is known as a tympanogram. Yes, tympanogram, right? Of course, this can be also your serous otitis media, right? Maybe your yes, of course it can be serous otitis media. Yes, doctor. Yes, glue ear can be glue ear, right? Of course. Okay. So also it is especially seen in the serous otitis media, which is your fullness of ear. And as it is in the male patient, which is the adult, will be there. So this is the tympanogram. So it is totally asking you about the tympanogram. Now I have to explain you what kind of, right? There is a what kind of the case the tympanogram. So there is a tympanogram is having the different type of it. So we have to talk about it. We have to talk about the tympanogram test. Right? So reply me in the chat box. What can be type of tympanogram when we seen? Type A, type B, type C, or type AD? Reply me in the chat box, guys. Which can be? I'm waiting for your answers. Of course, as already I told you, what is the diagnosis here? The diagnosis is the same. Serous otitis. Of course, if the serous otitis media is there, of course, this can be your answer will be your type B. Very good, guys. I agree with you. I agree with you. But but I'm not here to explain you just the option which is given in the answer. I know this type B is seen in the SOM, which is the serous otitis media. And what is this? Of course, what it can be seen? Of course, it can be seen when your middle ear filled with fluid or pus. Maybe pus is accumulated there, or maybe there is the, of course, maybe there will be the your some fluid is accumulated there. Now tell me, what about the A, where we can see the type A tympanogram? Anyone of you guys? Of course, one doctor is applied about the AD. Very good, doctor, very good. The AD is seen in the disruption of, please remember, the mean of D is what? The D is locating us that there is a disruption of ossicles. Yes, whatever the bones. Yes, ossicle dislocation. Yes, we can say the same disruption or dislocation of the your ossicle. Whatever the bones we have, the right malleus, incus, or stapes, this can be dislocated. Yes, this can be dislocated. Very good. Type A is the normal. Very good, doctors. Very good. यस, टाइप ए किस में दिखेगा? नॉर्मल पर्सन में दिखेगा. वेरी गुड, वेरी गुड. टाइप बी ऑलरेडी टॉक्ड अबाउट इट. एसओएम में दिखेगा. सीरस ओटाइटिस मीडिया कैन बी सीन इन द सीरस ओटाइटिस मीडिया with the fluid filled cavities, and also it can be seen with the pus will be accumulated. What about the C? What is about the type C? Where it will be going to see? Where it will be going to see in the type C? Yes, very good. There is a AS type also. Yes, we'll talk about the AS also. Just write it down, all the things. I'm going to show you with the images also, guys. हम images के साथ भी एक बार फटाफट से इसको cover up कर लेंगे. So if they can ask you about the image based question, so please remember the AS, as the as mentioned is there. What is the mean of AS type? Yes, this is seen in the your, yes, this is seen in the your otosclerosis. Yes, yes, otosclerosis. Very good, doctor. Dr. Rekha, right? Very good, doctor. Your type C is seen. Your type C is seen the when your blockage of station tube, or we can say the ET dysfunction, station tube dysfunction, right? Yes, this will be seen. This will be seen that totally. Yes, this will be seen in the type C will be going to seen in the your station tube blockage. So this is all about which is going to we have to see in the tympanogram. So just I'm showing you the image of it. So this is the type B as we talked about it. So this is the image of your tympanogram, guys. Tympanogram. Just talked about it as we talked about it. Everything. Just summarizing you in the image pattern also in the image manner also because maybe sometime what they are drawing us only a single tympanogram and maybe they can ask you without the given the name or without the given the labeling over it and they can ask you what can be seen. This the tympanogram is given by the XYZ patient and what can be seen there. So just write it down. You can see this is the A. This the A is your normal. Yes, it can be seen in the normal. And you can see AS. Can you see it is a smaller than AS is your is smaller than the normal one also. Of course, as I already told you, it is seen in your autosclerosis. Yes, autosclerosis. Yes, it will be seen in the autosclerosis, right? And of course, the next we have the type AD, which is seen in the your dislocation of ossicles. Yes, there is a dislocation of the ossicles. Yes, very good, doctor. Dislocation of ossicles. Now you can see what is the type C. Just check it out. The type C. This is looking like same the type A. Just it is more on the negative side. Can you see? Write it down here. More negative. Yes, the type A you can see there. The type A is clearly seen, which is on the near the zero. Yes, you can see. But if I'm taking out it to the more negatively, this is the type C. And of course, in the type C is what? There is a ET dysfunction. Yes, your station tube will be going to not the work. Now, the type B, can you see the type B? Just write it down in front of type B. There is a flat type of. There is a flat type of curve will be going to seen on the type B, and you can see it is totally flat. Can you see this is a totally flat line will be going to seen over the tympanogram. Of course, it will be going to see on the your SOM. Yes, serous otitis media or fluid filled middle ear. Yes, in the middle ear if the fluid is filled there. All right. Yes, doctor. The C will be going to see in the case of the negative pressure in the ear, of course. Right. The same if the station tube is totally black, as we talked about it, the station tube is doing what? It will doing the yes, it is doing what? It is doing the your ventilation or the pressure maintenance. Yes, pressure maintenance. Yes, of course. Glue ear is also you can write it down here. Yes, you can write it down the glue ear also you can mention here. Is it clear about the tympanogram? Let me know in the chat box. Is it everything is clear about the tympanogram? Very important topic, guys. It can be asked you in the exam on the basis with this graph also, or maybe they can ask you directly also, right? On the tympanogram, A S type of pattern is seen, A D type of pattern is seen, or maybe B type of pattern is seen, all right? C is seen, right? Very good. Let's move forward. The next question is in front of you. Very good. What is the specific sign associated with the bluish discoloration over the mastoid? So I hope you know about the mastoid. What is this mastoid? There is a bony, yes, there is a bony part which is the behind the pinna. Yes, just behind the pinna we have. Very good, very good. It's clear. Very good. All right. So what should be it is known as? What should be it is known as? Very good. Option A is given a battle sign. Battle sign, Ratter sign, Chorbeck sign, and the Romberg sign. Of course, very good, guys. Very good. This is the battle sign. And what is the battle sign? Very good, doctor. You already studied. There is the ecchymosis. There is the ecchymosis on mastoid part. And what is the reason of it? Can you tell me what is the reason of this ecchymosis on the mastoid part? Can anyone of you can tell me? Can anyone of you can tell me? Can anyone of you can tell me where will be going to see this mastoid part? The ecchymosis will be going to see in which condition? What can be the condition will be there? I want to ask you about the condition. Very good, doctors. Yes, this will be your fracture of middle cranial fossa. Yes, it can be the fracture of your middle cranial fossa. Guys, please remember if the anterior, yes, there's a base of skull is the your middle cranial fossa. Yes, fracture of, you can write it down, fracture of skull base. Yes, base of skull. Yes, skull base fracture. Also it is seen in the, if there is a middle cranial fossa, this is the middle cranial fossa is there, anterior cranial fossa is there, posterior is also there, and middle also there. So if the middle cranial fossa will be there, there is a bleeding will be coming on the scene on the mastoid process, yes, this will be your battle sign. This will be seen your battle sign. So you can see this battle sign image. I can show you here. You can see over here. This is the bluish discoloration seen over the your mastoid part. Yes, over the mastoid part, and yes, this is your battle sign. Yes, this is your battle sign. Very good. Very good, guys, right? Of course, it will be seen in the fracture, right? Seen in the trauma condition, middle cranial fossa will be fracture. Yes, middle cranial fossa will be going to fracture in this condition. So we have to see, as we saw the battle sign, we have to do what? We have to do the NCCT. Yes, non-contrast enhanced, yes, non-contrast computerized tomography, right? Right? Yes, in the anterior there will be the periorbital, which is a raccoon eyes. Yes, you already know very well, right? From the FMT and the ophthalmology, you know very well that in the anterior cranial fossa, if the anterior cranial fossa will be going to fracture there, they will be going to see in what? They will be going to see in your, yes, they will be going to see the periorbital ecchymosis. Yes, periorbital ecchymosis on the both side, and this is known as your raccoon eyes. The eyes will be going to give you the raccoon eyes. Yes, raccoon eyes sign in the anterior. Very good. We're going to do the NCCT. Of course, NCCT will prescribe. Yes, in the making the diagnosis, for the making the diagnosis of it. Very good. In the orbital floor fracture, please remember, orbit floor fracture, there will be the blowout fracture. Yes, there will be the ecchymosis below the eye. Yes, inferior to the eye, not the raccoon eye. Yes, raccoon eye will be going to seen in the anterior cranial fossa fracture. Yes, anterior cranial fossa fracture. Okay, okay, doctor. Very good. Let's move forward for the next question, which is in front of you. Which sinus absent at the birth? Very good question. Sometimes we are getting confused in this question, but this is regularly they are asking related to the your question related to the your sinuses, right? Paranasal sinuses. Now tell me, guys, here they clearly mention to you which sinus is absent at the birth. They clearly mentioned. So option is given the frontal sinus, option B is given the ethmoidal sinus, option C is your maxillary sinus, and option D is your sphenoid sinus. I'm waiting for your answers, guys. I'm waiting for your answers. I'm waiting for your answers. Please reply me in the chat box if you know about little bit about your sinuses, paranasal sinuses. You know about it. Yes, you know about it. Okay, very good. Very good. So your answer is here the frontal sinus. Your answer is here frontal sinus. So just to write it down, doctor, not the sphenoid sinus. The sphenoid is present at the birth. Yes, sphenoid is present at the birth. Please remember. Okay, sphenoid will be going to present it there. Yes, very good. Now, write it down some important things which they can ask you related to this. So just write it down here. Write it down here in the front of the frontal sinus. It absent. It absent at birth. And what can be the in the development? Of course, it developed at last. So out of this, all the sinuses, it will be going to develop at the end of it or the end of it. Yes, very good, very good. I'm going to give you the same mnemonic, doctor. Maxillary, ethmoidal, sphenoidal, and frontal. Very good. We'll talk about it. We'll talk about it. Right? So just remember this. So answer should be your frontal sinus. So answer should be your frontal sinus. And please remember, just check it out about this and explain you. So this is the your frontal sinus over the your frontal bone. You can see here, right? Over the frontal bone. Yes, fully developed at the 6 to 7 year. We'll talk about this also. We'll talk about this also. Very good, doctors. Very good. Yes, 6 year. Near the 6 year, it will be going to develop at the last of it, right? Then also we have the sphenoid sinus and ethmoid air cells and the maxillary sinus. So write it down here. What is the total? Yes, what is the mnemonic you have to remember? Please write it down. Maxillary. Write it down. Maxilla. Then write it down. Ethmoid. Then write it down sphenoid, and last you have to write it down, which is your frontal, and make a mark greater than here. So it is your first. Yes, please remember your first is, yes, MESF. You have to remember this mnemonic, MESF. Very good. So you have to remember this MESF and this maxillary, ethmoid, sphenoid, and frontal. We have to talk about the depth of this also. Please remember your maxilla is your first sinus which will be going to develop in the child, and of course it will be going to present at the birth. Of course, then the ethmoid and the sphenoid, and this will be your last. Okay, which one is the last? Yes, your frontal is the your last one. Frontal is the your last one, right? Mass food, not the mass food. Okay, very good. Some important thing, write it down about this maxillary sinus. I'm writing down here. Please write it down. This is at the largest sinus. Please remember, this is the largest sinus, because as you can see over the image also, this is covering a very big area of our cheeks, right? And what is the volume of it? It is a volume of your 15 ml. Okay, what is the volume of it? Write it down here. Just write it down here. It is your 15 ml. Okay, write it down. It is just the 15 ml. Yes, about the water's view and all the views related to the x-rays will be going to cover, doctor, in the radiology, right? Soon we have the radiology sessions also, right? I'm announcing here only, right? Soon we're going to do the radiology session also about the all the views related to the ENT, related to the your neurology, medicine, surgery, everything related to the radio diagnosis will be going to covered in that particular session. It will be a very nice session. Just wait for it. Just wait for it, right? Now, this is about the your maxillary sinus. Now, with this also, we have to talk about the ethmoid air cells. Guys, this is not as known as the ethmoid sinus because it is having the different cells will be. It is not a single particular big sinus will be there. There is having the different of this. So there will be the 8 to 9 cells are there which will be going to together, and this all is known as ethmoid air cell. Yes, of course, this all will be going to known as the ethmoid air cells. Now, there we have the bulla ethmoidalis. Write it down. Write it down, guys. Bulla ethmoidalis. This bulla ethmoidalis is the largest cell of ethmoid air sinus. What is this? Yes, this is the your largest cell of the largest cell of it. Guys, not the 8 to 9 ml. It is about the 8 9 cells. The group of cells is there, right? 8 से 9 cells है जो छोटे 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 वहाँ पे participate कर रहे हैं, right? So this all are together will be going to make your ethmoid. Yes, it will be going to make your ethmoid sinus. Okay. Now, the bulla ethmoidalis is the your largest cell. The next we have, there is a agar nasi. Write it down. This all are the important question, right? Write it down. Agar nasi. This agar nasi cell is the your anterior most cell. Agar nasi is the anterior most air cell. Anterior most air cell. Yes, largest is bulla ethmoidalis. I also written, doctor, there the bulla ethmoidalis only. And yes, anterior most air cell is the your agar. The same I written, doctor. The same I written, doctor, there. And of course, if I'm talking about the next one, which is your, write it down, which is your Haller cell. Haller cell, guys, what is the importance of this Haller cell? Write it down. This is below the orbit. Yes, it is here, just below the orbit. Yes, A for आगे, है ना? A से आगे. Yes, आगे means agar. Very good, doctors. Very good. You already remember all the mnemonics from there, right? Yes. And last one, which we have the onody cell. Yes, we have the onody cell is there. And what is the role of this onody? Onody cell is the your just just near the orbit. Yes. Yes, below the orbit is Haller. Below the orbit is Haller. This all are, guys, very very important, very important for the your ENT paranasal sinus topic. Okay, they can ask you about this any of it, which is the largest, which is the anterior most, which is the below the orbit, which is the near the orbit. So you have to remember this. Bulla ethmoidalis is the largest. By the name only you can see the bull-like moidus. It is seems like there is a something big is there, okay, right? And of course the organizer is the आगे. Yes, जो सबसे आगे वो anterior most है, and halar is the below the orbit, and near the orbit is the your onody. Yes, onody is the below the orbit. Okay, very good, very good, guys. Let's move forward. Right? Is there any queries related to this? Please remember the last one, which is the frontal, which is the last one. Okay, and developed at what age? 6 to 7 years age, fully developed. Okay, fully developed कब होगा? Yes, 6 to 7 year of the age. 6 to 7 year of the age, it will be fully developed. It will be going to fully developed it. All right, very good. Let's move forward. Let's move forward for the next one, which is in front of you. Which is in front of you. Now, there a 21-year-old. There's a 21-year-old female presenting with what? Presenting with the headache, presenting with the fever, presenting with the difficulty in the breathing through the nose. Yes, there is a no difficulty breathing. There is a no difficulty breathing in the through the mouth, guys. Yes, thank you so much, doctor. Thank you so much. Yes, it's quite good session, right? Quite good session, covering all the important things, covering all the important things, right? And and there is a clinical picture shown in the image. So can you see in the clinical image also? It's shown to you something, right? Very good, right? Okay. So this is asking you about it. What is the what is the your diagnosis in this condition by the seeing this picture, and option is also given to you, guys. Option is given to you: A, which is your antroconal polyp; option B is given you the tubotympanic polyp, and option C is given you the septal hematoma; option D is given you the septal abscess. Now I'm waiting for your answers, guys. Please try to reply me in the chat box. And guys, please remember, always and always, we have this session, right? I'm always creating some difficult MCQs for you, so you will be getting a little bit confused, right? So always think about it twice before the answering the answers in the session. Very good. Guys, everyone you are answering the septal hematoma. Everyone you guys are answering as the septal hematoma, as you saw there. Guys, can you tell me What is the mean of the septal hematoma? Just I'm clearing you it. Just I'm clearing you it here only. What is the mean of the septal hematoma? Of course, on the septum there is a, yes, there is a, what will be happen? It can't be the bilateral, so it's bilateral, so can be the polyp. Of course, this is the thing is clear to you, doctor. Very good, doctor. I am agree with you. Just tell me what is the septal hematoma. Of course, there should be the history of trauma will be there. Is it given to you in the MCQ related to the septal hematoma? Of course, there is a, some injury of the, there is an injury of the nose will be going to given, because without the injury is not possible, guys. There will be the scene, the hematoma can be seen there. Okay, the first thing, the first thing, there will be the, in the septal hematoma is there, guys. Please remember, in the hematoma there is a no fever. Can you remember now? As I told you in the hematoma of ear, we talked about the boxer ear just few questions, right? Just few questions previous I talked about it. Now tell me, is there was the, they clearly mentioned there was a no fever was there, right? Right? Yes, epistaxis may be there, but please remember in the epistaxis there is a septum will be going to bulge out of there. Of course, I can be axis, right? So in the epistaxis also maybe the history of trauma will be present. But tell me, in the epistaxis the fever history will be there, doctor? No fever will be given, right? No fever will be given. Okay, so fever will be not there, but yes, in this case they clearly mentioned the fever is present there. Yes, the fever is present there. And also they mentioned you about the headache also. They also mentioned here about the headache also. So it is clearly saying to me, if the no fever in the septal hematoma, so it's not possible, as the option is totally mentioned the fever is there. History of trauma is also not available there. Guys, now tell me what can be possible. Of course, as you are saying option A, of course, as it is the bilateral, your anteconal polyp is the seen, most commonly seen unilaterally. Yes, of course, doctor, it will be seen in the unilaterally, and there will be the your anteconal polyp, the tubotympanic polyp. Your tubotympanic polyp, it will be what? It will be also, it will be also can be the unilateral. Of course, the firstly it will be unilateral, plus it will be present the middle ear infection. Middle ear infection will be presented there. Of course, middle ear middle ear infection should be presented there. So what is our final diagnosis? Yes, your answer should be in this condition is your septal abscess. Yes, so your answer is here the septal abscess. At the abscess is there, guys. Now tell me, abscess is occurred there. So this abscess will be going to create what? Of course, fever will be present. Yes or no? Yes, fever will be, of course, there will be the fever will be seen. Very good, doctors. Yes, fever will be going to seen. Of course, headache is present. As is the mentioned there, as there is a septum will be going to bulge because of the abscess. So, of course, difficulty in breathing through nose. Difficulty in breathing through nose. This all will be going to present it there. So just one thing which is related to your fever, right? It is going to confuse you, right? So otherwise, just think about it. Just think about it. This clear point is given, which is a key feature, right? This key feature will be going to make, this key feature will be going to make the clear things between the septal hematoma and the septal abscess, right? So please, my request to you again, right, guys? My request to you again, in the exam, please remember, in the exam, please read the question very carefully. The first thing, you have to read in the calm, right? Please keep calm and read the MCQ very well. What is the examiner want to ask you? And after that, reading the all the options. It's not like that what you are doing in this question. Option A, you read it. No, polyp will be the unilateral. Option B is this is also the polyp, unilateral. Option C, okay, just put it the option C. Please try to read the option D also. This is my request. This is my request to all of you. Please try to read it out, all the MCQs, all the option after the reading the question, and then try to make your decision. Like what will be the answer, right? So don't do mistakes, this silly mistake. This is known as the silly mistakes. You know about it, about the septal abscess, you know about it very well. But yes, because of the hurry, you are making such silly mistakes, right? Let's move forward. Okay, guys, I hope is that clear to you, everyone? Is it clear to you? Very good. Let's move forward. Let's move forward. Very good. So now you will be remember these things, right? You will be not going to mistake on the exam day, right? On the exam day, you will be not going to mistake this. So the answer will be your septal abscess. Your answer will be here septal abscess, right? Very good. Should we explain this thing? I already explained you on the same slide only. On the same slide only. Now, the next question is in front of you. The next question is in front of you. Now, what is the most specific test? What is the most specific test is used to confirm? Please remember they are asking about the most specific. For the confirm the presence of CSF in the CSF rhinorrhea. If the CSF rhinorrhea is there, how I can confirm this? That is the particularly CSF rhinorrhea is only there, or maybe some nasal discharge is there, right? How I can confirm this thing? Can anyone if you can tell me? The option is given to you. Yes, the option is given to you. Option A is the beta 2 transferrin. Option B is the reservoir sign. Option C is your glucose estimation test. And yes, option D is your handshake sign. What is the specific? Very good, doctors. Very good. Everyone is replying very well. Option A is the beta 2 transferrin is the most specific. Guys, all the sign is related to this only. Please remember, let's talk about it. Let's talk about it. So, what is the CSF rhinorrhea? First of all, let's talk about it. What is the CSF rhinorrhea? So, there is a CSF, please write it down. There is a CSF leakage from nose, or you can write nasal cavity. Yes. So what I'm going to see there, what I'm going to see in there in the CSF rhinorrhea, the rhinorrhea, it means the CSF is going to leaking out, or the CSF is flowing out from the nose. This is known as the CSF rhinorrhea. CSF rhinorrhea. Right? Yes. Very good. Now, this is the, if I'm talking about the beta 2 transferrin, please write in front of you. This is the your most specific. This is the your most specific test for this. Yes, for CSF rhinorrhea. Yes, this is about the CSF rhinorrhea. Of course, we'll talk about the causes also. Yes, just wait for it. Just wait for it. Just cover up this all the things. Okay, just cover up this all the things. And now, what is the glucose estimation test? Of course, we are doing this glucose estimation test. In the glucose estimation, in this test, if glucose levels is more than 30 gram, yes, it means CSF is present. Yes, so in the CSF rhinorrhea, we collected the fluid which is leaking out from the nose, and we did the glucose estimation test. In this glucose estimation test, if this is more than the 30 gram, if your glucose levels in that is the more than 30 gram, it will be your glucose estimation. It will be your what? Yes, it will be your CSF. Also, what we are doing in the handkerchief test, on the handkerchief test, what we are putting this with the fluid which is leaking out, we are putting it on the handkerchief, and what it will be going to give? Of course, it will be going to give you the halo sign, or it is also known as the target sign. Yes, it is giving kind of this kind of the sign. Yes, target sign or the halo sign will be given on the handkerchief test. So these are all the tests of this. On the reservoir sign, what will be seen? As we'll be going to do the endoscopically, we are going to see there. So it will be looking like that. There is some reserving will be there on the backside of the sphenoid, and there is some leaking out of the fluid. It is known as the reservoir sign also, right? So this all are the sign of the your CSF rhinorrhea only. But if I'm talking about it, which is the most specific? Yes, your most specific your beta 2 transferrin. Beta 2 transferrin. Okay. So remember about it. Which is the most specific? Yes, your beta 2 transferrin is the most specific. Most specific your beta 2 transferrin. Yes. Is it clear? Let's talk about it. Let's talk about it. Just a minute. Now, let's talk about it. This is about the CSF rhinorrhea. Let's talk about it, the CSF rhinorrhea in a full topic, which is important topic. So you can see here what is the traumatic here. So you can see here where is this trauma. Yes, this is what, this is the your cribriform plate. Yes, what is this? Yes, this is the cribriform plate. And what is the cause of it? This is the cause of the fracture of, there is a fracture of cribriform plate. Yes, there is a cause is what? The fracture of the cribriform plate is the fracture. Yes, very good. So there will be the leaking out. Can you see? This is the cribriform plate. There is a fracture. So the fracture will be the cribriform plate. Can you see? This cribriform plate is dividing our brain cavity will be there, and there is a nasal cavity. This is the connection. Yes, you can see this will be going to above. We have the brain. Yes, and below this we have the above we have the cranial cavity. Below we have the nasal cavity. So this is the connection between it. If it will be going to fracture out, so from here your leaking out fluid will be your CSF. Yes, as your CSF is filled in the your cranial cavity. Yes, as your CSF is yes, in the cranial cavity. So this will be going to secrete out here. Now tell me what should be your diagnosis for the making the diagnosis. What is the best thing which you have to do the test? Tell me, guys, what should be done in the diagnosis? Yes, for the making up is the diagnosis we have to do. For the making up the diagnosis, we have to do the HRCT, high resonance CT scan should be done, which is the giving the best results. Yes, best results should be given here. But if it is not available, so we can do or we can do we can do your MR cystography, mammography, mammography should be done, right? But best one, if you are asking about the best one, make a star here. Your HRCT is the best, right? We prefer the HRCT will be there. Now, what should be the treatment part? What should be done in the treatment part? If the fracture will be there, of course, it should be the conservative treatment is only. What is the conservative treatment? Please remember what is the conservative treatment. Of course, we have to give the bed rest to the patient for more than more than 15 days. Yes, we have to give the bed rest to this patient for the more than 15 days, right? So this should be the conservatively management by the CSF of the CSF rhinorrhea. Yes, is it clear to you, everyone? Is it clear to you, everyone? Right? And please remember what are the tests are the most specific. We already talked about it. So this is what? This is the beta 2 transferrin is the most specifically. Yes, most specifically. Yes, it's near the some of in the some book they mentioned the 2 weeks. Some of the books are mentioning the 15 days. Okay. Yes, it's approx guys. The 2 weeks is the only the 15 days, right? So some of the books are mentioning the 2 weeks. Some of the books are mentioning the 15 days. Okay, right. Yes, reservoir sign is the seen in the mastoiditis on the ear, guys, on the ear, right? On the CSF rhinorrhea also, there is a, on the endoscopically, if I am seeing, there is a reservoir sign is also seen. There is reservoir sign on the, seen on the mastoiditis also. Yes, on the mastoiditis, it will be seen on the otoscope. Yes, not on the endoscopy, it will be on the otoscopy when I'm seeing the ear, right, through the otoscopy. Very good. Yes, doctor. Yes, very good. Right. Let's talk about it. Okay. Yes, conservative management for the 15 days. Very good. Now, let's move forward. Let's move forward. Let's talk about this topic also. A 26-year-old man. Just highlight this. Presenting with the history of nasal bleeding. Patient is having what? The patient is having the nasal bleeding over there. And with this nasal bleeding, the patient is having the difficulty in the breathing. And the histopathological examination showing the following, and this is the following, you can see the histopathologically, and what should be the treatment for this. For the first of all, going with the such MCQ, we have to make the diagnosis. So can anyone, if you can tell me what is the diagnosis is here? What is the diagnosis is here? Yes, what is the diagnosis, guys? I'm asking you about the diagnosis. Tell me what is the diagnosis, guys, here? Very good, very good. So first of all, write it down here. As the clearly mentioned, the man is there, nasal bleeding. Please remember, nasal bleeding. Histopathological examination. As the clearly histopathological examination is given, what is the scene in here? Can you see these are the round shaped, right? And this is what? Yes, this is the diagnosis your exactly is your diagnosis your rhinosporidiosis. Yes, your diagnosis is what? Rhinosporidiosis. Yes, yes. Rhinospori. Yes, and what is the cause of it? Please write it down. Rhinospori sebri. Write it down. Yes, sabri. The rhinosporidiosis sabri is the cause of the your rhinosporidiosis. Exactly. And what will be the scene? Can you see? It will be the unilaterally, guys. It will be seen in the unilaterally. And what is this? Yes, this is the your mulberry like nasal mass. Very good, guys. This is the your mulberry like nasal mass. Yes, this is the your mulberry like nasal mass. All right. Very good, very good, very good. Let's talk about it more deep. Just wait a minute. We'll talk about later. Just talk about the rhinosporidiosis in this page, and then we'll go at the part of treatment. We'll go there. Just write it down. Rhinosporidiosis. Okay. What is the cause, guys? Cause is your rhinosporidiosis cerebri. Yes, rhinosporidiosis cerebri. And yes, where it will be going to seen? It will be seen in coastal area. Yes, it will be going to seen in the coastal area. Particularly kind this of the question there in the history of pond and the coastal area of India. Yes, doctor, if they are mentioning you, guys, what can be seen there? If they are mentioning you, you will be going to catch this key point. What the examiner want to do? Please listen this part. Examiner want to do the confuse you. Just the examiner want to confuse you. That's why maybe it can mention it will be mentioned there, maybe it will be not mentioned because they given you a big key point. Can you see what big key point is given? This image is the big key point. That's why they didn't mention you about the history of pond or maybe the coastal area. Okay, they didn't mention you because as you will be going to see this histopathological image, this will be totally clear to you. Yes, this will be though totally clear to you that it is done from the yes, it is done from the your your rhinosporidiosis seborrhei. Is it clear to you? Now it will be seen, guys. It will be seen in the coastal areas. And what kind of the coastal area? If I'm talking about in India, In India, it's seen, it most commonly seen in Tamil Nadu. Yes, it will be most commonly seen in the Tamil Nadu. Yes, doctor, I can understand. On the polyp is also, yes, polyp is also can be there, but please remember about it. In the polyp, the histopathological picture will be not given to you. Okay, so the clear cut picture is which is given, which is the histopathological. It will be giving me the clarification. Is that clear? Yes, yes. So most commonly it will be seen in the India, Tamil Nadu and Kerala. Okay, and if we're talking about the worldwide or the most commonly it will be seen in the Sri Lanka also, because Sri Lanka is also your coastal area. Yes, it will be seen in the Sri Lanka also. Okay, and yes, there will be the history of maybe the pond or the this, and what is the two important key feature? Of course it is your aquatic, what it is your aquatic protozoa. So of course there will be the history of, yes doctor, there will be the history of pond bathing will be present. Yes, so there is a history of, yes, there will be the history of the your pond bathing will be there, and also this the polyp which is seen, it is giving the as the appearance, the nasal is giving the polyp is given as the strawberry like appearance. Yes, strawberry like appearance is given by the nasal polyp. Now, what should be the treatment? Now, guys, you can tell me what should be the treatment should be given in this condition. Of course, the first of all, we have to give the dapsone should be given. There will be the dapsone should be given, and of course, plus after that we can do the cautery excision. Why the cautery excision? Because it is having the proper blood supply. Guys, please remember, as it is having the total blood supply will be there. If I'm not doing the cautery, it will be going to bleed too much. Okay, so we'll do the cautery excision, which is the your surgery. Yes, it is a part of the surgery. So the in the medical management, I will give the dapsone should be given. Yes, you can write it down. The dapsone is your drug of choice is also here. You can write it down. Okay, doctor. Yes, dapsone is your drug of choice. Okay, you can write it down. And after that, we can do the cautery because this will be going to bleeding. As in the image, you can see there is a clearly given that it is a nasal bleeding is seen from there. So of course, when we are doing the surgery, if the simple excision is done, it will be going to do the bleed, right? It will be going to too much bleed will be there. So that's why we have to do the cautery excision should be done. The cautery excision should be done. Very good, right? So now tell me what should be in this option. The first is the your anti-tubercle therapy. Of course, it is not, doctor, it is not by the your Mycobacterium tuberculosis. So we're not going to do the ATT will be there. The dapsone therapy, of course, the dapsone is the drug of choice, but only dapsone will be not going to work there. If I give the only the dapsone, yes, the drug of choice is the dapsone, but the only the dapsone will not do the anything the work. Of course, the surgery which is followed by the your dapsone, yes, of course, it will be the your answers will be there, and yes, your answer D should be the not possible. Corticosteroids and the immunomodulators should be given in this condition. No, if you are giving this steroid and the cortic, it will be not doing any help in this rhinosporidiosis. So there is a no need of your corticosteroids in this condition. Is it clear to you? Is it clear to you guys? Please remember, if they don't mention, please remember, if they didn't mention about this, so what you have to remember? Yes, you have to remember with, yes, you have to remember with what? You have to remember with the histopathological image. Okay, doctor? Yes, surgery which should be the followed by the dapsone. So dapsone should be given and then surgery should be done. then surgery should be done. Is it clear? Very good, guys. Very good, guys. Let's move forward. Let's move forward. Now, the question number 12, which is in front of your screens, that which test is shown in the image? And they're asking you about the options. The first is your Apley's maneuver. Option B is your Hamlich's maneuver. Option C is your Cottel's test. And option D is your Totter's test. Option D is your Totter's test. Tell me, guys, what should be the your test which is seen here? Can you tell me? First, tell me what is the test, and with the answering with this, what is the test? Please reply me. It is done in which? It is done in the which condition? It is done in the which condition? Yes, of course. The answer is your Cottel's test. Agree with you. Agree with you, guys. Just tell me. It is seen in which condition? This Cottel test is seen in which condition? Where we are doing this Cottel test? Just tell me. To check the patency of nasal wall. Yes, very good. But in which condition? In which condition? Yes, we are checking the nasal wall patency. I agree with you. But in which condition? Of course, we are doing this test for the nasal patency in the your blockage in wall, abnormal nasal wall. Yes, this is the investigation done in the your in the deviated. Write it down, guys. Deviated nasal septum. Yes, yes, of course, the nasal wall blockage will be there. I can understand it will be seen. It can be mostly we are doing this in the DNS. Yes, if the nasal is your nasal septum is the diverted. Yes, if the nasal septum is diverted, we are doing this Cottle test also. And what we are doing, we are saying to the patient to look upwards, and we are seeing the what? We are seeing the where is the nasal opening is the yes, where is the nasal opening is the bigger. Yes, in the DNS only. Yes, we are doing in the DNS only, right? Very good. Very good. So this is about the Cottle test. What is the Hamlich's maneuver, guys, then? What is the Hamlich's maneuver? Let's talk about this Hamlich's maneuver also. What is the Hamlich's maneuver? Can anyone of you can answer me? Hamlich's maneuver is done in where? In which condition we are doing the Hamlich's maneuver, guys? In which conditions we are doing the Hamlich's maneuvers? Yes, guys. Please remember, we are doing in this Hamlich's maneuver in the some food particle obstruction on the your trachea. In trachea. Yes, which is what? Which is known as your choking. Yes, it can be choking by while the eating most commonly seen. Guys, the choking is seen by the food particles. Most commonly the food particles, like especially your cake. Yes, while the eating the cake, the Hamlet, what the choking will be seen. The trachea will be going to totally blocked by this cake, and we have to do the Hamlet's maneuver. Yes, Hamlet's maneuver. Very good, guys. Very good, guys. Let's talk about it. Let's talk about the your DNS, which is your deviated nasal sinus. Write it down. Let's talk about it. It's an important topic. Deviated nasal septum. Yes, right. So what is this? Yes, BPEV, we are doing the Apley's maneuver. Very good, guys. I forgot to write it down, mention here. Yes, this Apley's is done in the benign prostatic. Yes, BPEV. It is also known as the abnormal truss. Yeah, BPEV Apley's maneuver we are doing. Yes, yes, Holpix Dix maneuver is also done. Apley's maneuver is also done. For the one is the diagnosis, and the Apley's is done for the, yes, 5 position, which is done for the treatment part. Apley's for the treatment part. Halpike Dix is for the diagnostic too. Right? Very good. Right? Very good. Let's talk about it. Let's talk about it. Your deviated nasal septum. So, guys, what is the deviated nasal septum? Just think about it. This is the your nose. Yes, and of course your nasal is divided by this is septum. Yes, your nasal is divided by the septum. If your septum is straight, yes, it will be the your normal. Yes, it will be the your normal. And if your yes, Applis, yes, Halpike's Dix maneuver is the your, yes, for the diagnosis. Applis is for the your, yes, Applis is for the treatment part. Yes, doctor, I already told you the same thing only, right? The next, what is the scene in the dan in the part of your deviated sinus? Just check it out. This septum will be going to deviate. What kind of deviation will be seen? It will be going to deviate like that. Okay, and due to there is a, like, if there is a deviation will be seen, so what will be happen? We have the concas are there. This concas will be do the hypertrophy. This concas will be do the hypertrophy, and yes, you can see it will be going to cover up the more part. Yes, this conca will do the hypertrophy, and this, because of this there will be the seen the obstruction. This will be going to cause what? It will be going to cause the obstruction. Yes, obstruction will be going to see, right? Through this conga there will be the obstruction will be going to see, and this obstruction will be here. This obstruction will be seen due to this conca. It will be the obstruction, and the mainly it is very small part. So the air obstruction, if I'm talking about the air obstruction, this will be seen on the same side. What is the mean of same side? It means which side we have the deviated septum, there will be going to seen, and of course sometime on the opposite side also. Yes, sometime on the opposite also. Now, also there is this hypertrophy. As we talked about this hypertrophy, what is this hypertrophy? This hypertrophy is known as, guys, write it down. This hypertrophy is known as complementary. Yes, complementary or the compensatory hyper, sorry, this is the compensatory, not the complementary, guys, sorry for it. This is known as your compensatory hypertrophy of inferior turbinate. Yes, it will be by your inferior, just a minute, guys, just a minute. I think the camera is stuck there. Just a minute. Sorry for this disturbance, guys. Sorry for this disturbance. Sorry for this disturbance. Right? This camera was stuck. Right. So we are talking about there is a compensatory. There is a compensatory of the inferior turbinate. Right? Am I clearly visible now? Am I clearly visible now? There is the nose stuck. There is the nose stuck. Yes. Right. So there will be the inferior turbinate. If this inferior turbinate will be doing what? Yes, this inferior turbinate will do the this. Very good. Right? And due to this compensatory, there will be the special thing will be seen, which is the severe headache. And this severe headache is also cause what? It is caused the anterior nose struck. I think there was a lag bit of the camera, right? I seen on my second screen the camera was lagged. I corrected it. I corrected it. I think now it's perfect, right? Okay. Now the severe headache will be going to seen with it is called as the anterior ethmoidal anterior ethmoidal syndrome. And of course, in this cortical test, of course, in the diagnosis, we can do the cortical test, or we can do the what? We can do the MRI also. We can do the MRI also, right? But what is the main in the investigation? We have to do the cortical test for the basic investigation. Of course, we are seeing the what the patient will be going to do the upward the neck, and we can see the openings. Yes, nasal orifice openings can be seen there, right? Can be seen there. And of course, what should be now the treatment, guys? Now tell me, what should be your treatment in this condition? I'm waiting for your answer. Yes, cellular neuralgia. Very good. Severe headache will be going to seen there. And what should be the treatment part here, guys? Very important thing is here. The treatment should be here the septoplasty. Of course, we have to do the septoplasty. Yes, we have to reconstruct. Yes, we have to reconstruct the septum of the nose. Yes, we have to correct the septum of the nose. Of course, after the surgery, we can give the mitomycin C. Yes, of course, we can give the right. And yes, of course, the septoplasty will be your definitive management is there. All right. So this should be done in the yes, this should be done in the case of your deviated nasal sinus or the septum. Sorry, deviated nasal septum. Okay. All right, guys. Is it clear? So in this condition, or in this today's topic of the important topics of the our ENT, we talked about the important the ear topics, right? One-sided septoplasty, guys. Septum is the total, right? Septum बीच में होता है ना. So we'll do the septoplasty. We'll correct it. Just we have to correct it. One side, two side ऐसा कुछ mention नहीं होता है ना. Okay, doctor. We have to correct the septum. Yes, we have to do the septoplasty. Is it clear, doctor? Now, listen this part. So in this today's topics, in the today's this session, we covered up all the important topics. Of course, right, doctor. I can't continue more over there, right? It's already 9 there, right? So sure, we'll take a one more session of the ENT, right? We'll take one more session. There will be going to cover up the throat. Yes, as the throat will be there, right? We talk about the ear, important things, and the nose we talked about already. And there will be the throat will be there. When you will be going to take the part 2, we'll think about it and we'll update you. We'll update you, right? Soon. Please follow me on my Instagram. Please follow me on my Instagram. Yes, guys, larynx and pharynx, throat, right? हम लोग वो कवर करेंगे पार्ट 2 में पक्का. Please follow me on my Instagram for more updates, like when we have the session of the next session we are having, right? Also, if you have any queries, you can directly contact me on my Instagram also. And if you don't have the Instagram, you can directly contact me over my username of my Telegram also, right? This is my username of the Telegram, so you can contact me over the Telegram also, right? Okay. So larynx, pharynx, and audiometry. Okay, if the audiometry is not clear to you, we'll take the audiometry also, right? हम लोग audiometry भी cover up कर लेंगे. No issues. 100 question for every subject. Okay, doctor. Okay, okay, done. 100 important topics, right? जैसा कि आप कह रहे हैं. Surely we'll try to do it, right? For FMG or NEET PG, mostly we are covering the FMG part this time, right? We are targeting the exam of the 12th January, right? Exam तक के लिए बंद कर दिए हैं इंस्टा. Okay, so you can see on the Telegram also, guys. I'm sending you the Telegram. On the Telegram also you are getting the update. Just follow or the subscribe the Madu Hub channel also. So when we are going to live, this will be going to give you the notification from the YouTube also, right? For YouTube also. Okay, so just subscribe on the YouTube also, and please press the bell icon, so it will be going to, yes, it will be going to give you the notification, right? You will be getting notified. You will be getting notified whenever we have the sessions, right? Also, we are uploading on when we are having the session before it, we are uploading we are uploading on it on the YouTube also, like we have the session of it. Yes, of course, it is on the 12th January on the 2025, right? We'll take the part 2 also. We'll take the part 2 also, where we'll be going to cover the larynx, pharynx, and the audiometry, as the doctor mentioned. All right, audiometry is also needed. We'll take the part 2 also. Okay, guys. Thank you so much. Thank you so much for showing your love for this sessions, right? And goodbye, good luck for your preparations, right? Thank you so much. Goodbye, good night. Goodbye, guys.